Good morning, Ray. Can you hear me? Oops, I cannot hear you.
Good morning, Dr. Bishop. My name is Muntadar.
How are you?
I'm-
Welcome. How do I pronounce your name? Dr.
Yeah.
Muntadar?
Yeah, I met you in Taiwan, Changung Hospital, 2009 and 2012 in Turkey, Gazi University, Ankara, Colorectal Cloaca workshop.
Yes, yes, wonderful. So I pronounce your name Dr. Muntadar?
Yeah, Muntadar.
Muntadar. And then
Dr. Moon. Dr. Moon, okay.
Dr. Moon?
Okay.
Perfect.
And go to Cincinnati 2016.
Uh-huh.
Dr. Bishop and Pena go to Colorado. I stay in 2 months.
Oh, that is
Did
sad.
the
So
Jason
now you have
research.
to come to Colorado then.
Yeah, next time.
And you are in which country are you?
2 months.
Oh, that is sad. So now you have to come to Colorado. There's a lot of echo.
Yeah, they've got a couple of speakers on.
And you are in which country are you?
Indonesia.
Okay.
Yeah, a tsunami city, Dr. Bishop. Aceh.
There's a lot of echo.
Yeah, they've got a couple of speakers on. Hold on, let me turn that off. I can turn that off. Indonesia.
Yeah, a tsunami city, Dr. Bishop. Aceh.
Perfect. Did you finally got case number 2, right?
Yes, I did. Yes.
I'm little English, Dr. Bishop. I'm sorry.
It's
I-
totally fine. Totally
It's
fine.
excellent. I told him before it was excellent.
And do we have the other person that it's joining, Ray?
Yes, they're all logging on now. So
It's Dr. Nanda,
yeah, she's coming in momentarily.
and she's from
She's from India.
India, Monica Nanda. India.
Ray, can you hear us?
Yes, I can perfectly.
Hi, good morning, Ray.
Morning. How are you doing?
Quick question.
Yeah.
We have Alfredo is here with me, and
Okay.
we will present through with my computer, with my
That's fine.
laptop.
Yep.
Would that be possible?
Yes, it is. Yep. He can just sit where you're sitting, and then we can just change. We'll change the name.
Cool. Wonderful. Thank you very much.
You bet. Thank you.
So Leah, Alfredo will present before you because he's number 2 and you're number
Right.
4, right?
Right. Yep.
Perfect. Okay, good. Hello. Ahí está Alfredo, va a presentar hoy.
Thank you.
You both can sit together and then when one is presenting, the other moves.
Morning, Dr. Pena.
Yes.
Morning, Dr. Pena. I have met you in Changung Hospital 2009 and 2012 in Ankara, Cloaca workshop.
What time is it?
Nice.
Okay, I'll get to Bye.
Leah and Alfredo, and there is another doctor that will be joining soon.
She's having a little trouble logging in, but I'm not sure why. Good morning, Dr. Pena. Andrea, do you have any problem if I open up the meeting right now? We're about 10 minutes, about 12 minutes out.
No problems. Let's open.
Okay.
And after the meeting, we can talk because we shall see you tomorrow.
Okay. Yes, definitely. So we're live now.
Ray, I see Dr. Monica Nanda as a participant, not as a panelist.
Yeah, we had to do it that way. She couldn't get the link to work, so I'm going to make her a presenter.
Oh, okay, perfect.
And she should be coming in now as a presenter. Here she is. Dr. Nanda, I see you made it through. That's good. Can you test your, there we go, your video is perfect. Can we test your audio as well, please? Can you turn on your microphone?
Yeah, good evening, and
Perfect.
thank you for letting me. Yeah. So, good evening, Dr. Pena, Dr. Bischoff, and all other participants.
We'll be starting in about 9 minutes, and you're going to be case number 3.
Yeah, thank you.
Dr. Nanda, usually you are the one that share your slides, but if you're having any trouble, probably Ray could share them. Just let us know, but usually the presenters share their presentation.
Yeah, actually, I am attending with a phone, so it will be difficult for me. And the connecting is also a bit of a problem. So if you can present it, that will be very nice. If you can just show the slides, yeah,
Ray,
from your side.
Yep, we'll get those set up and ready to go.
perfect. Good.
Thank you so much. Thanks. Thanks.
Good morning, everyone, and welcome to our International Colorectal web meeting. Today, we have pediatric surgeons joining from Libya, South Africa, Philippines, Indonesia, Mexico, India, Uganda, Turkey, Uzbekistan, United Kingdom, Colombia, Iraq, and United States. If I miss your country, please type in the chat and we will acknowledge at the end. So first, I would like to welcome Dr. Moon from Indonesia, and it's a coincidence, but today all cases will be about Hirschsprung. So Dr. De La Torre, be ready. We need all the comments. Welcome, everyone. Dr. Moon, you can share your screen and start the presentation.
Thank you, Dr. Bishop. Good morning, Dr. Pena, Dr. Bishop, and Dr. De La Torre. I'm happy as we are all together here in this opportunity. Please let me present my case report. I have case residual Hirschsprung associated enterocolitis with anemia. Male, 8 years old, patient referred our hospital, 8 hours from my hospital. History, 4 years old, I'm performed like so of a transanal endorectal full through, and this lost control and anal dilatation, one dilatation. After that, no control my hospital. The patient also had complaint abdominal distended and diarrhea, and 5 days before admission to hospital, lack abdomen and black stool. These clinics and diarrhea and distended and laxantia chronis after operation, and laboratory result hemoglobin 9.1 and hematocrit 20%. This radiology examination, dilatation of bowel, megacolon, and perform diagnosis residual Hirschsprung associated enterocolitis, and examination rectal tussure. We have partial stenosis, and radiological examination barium enema. We have dilated like bowel and showed appearance with irregular mucosal lining and pneumatosis, and dilated zone and transitional zone have. And after patient general condition improvement, blood transfusion and barium enema examination, we decided redo transanal endorectal full through like Swenson surgery for this patient. Intraoperative report, perform lithotomy position and dentata line identified and anal retractile anal, and we stitch suture 1 centimeter from linea dentata, and incision mucosa and serosa and muscle. If I'm released the Rumon and pull through approximately 25 centimeter, suspect ganglionic and resected, and have diameter colon to 11 centimeter. We decided to do tapering with echelon stapler. We perform diameter 5 centimeter, and we perform coloanal anastomosis, interrupted double layer, PGA 3O. Operation complete, and pathology laboratory, we have aganglionic distal and proximal ganglionic. This operative report, we perform 1 state operation. After perform tapering from a stapler. After undergoing surgery, patient chief complaint resolved, feces color was normal, and patient no distended anymore. This and fecal good and no defecation. Thank you. That all the thing that I could share. I'm sorry if there was any wrong statement that worry you, and I hope any comment this case. Thank you. I hope the laboratory this confirm this case. Thank you very much.
Thank you very much, Dr. Moon. Usually we like to say we don't argue with success. Your patient came with problems, you operated, and now the patient is doing well. So congratulations. But I think the purpose of this meeting is also to advise others in a similar situation. So number one, it's important to emphasize that patients with Hirschsprung, even after a perfect initial operation, which obviously in this case it was not because the patient had residual aganglionosis, patients need follow-up. So most of these patients are operated during the newborn period when they are still being breastfed or just being fed by formulas. But once they start food, there will be a change. So many of these patients suffer either from severe constipation, diarrhea, so they enterocolitis. So these patients need follow-up. We tend to blame on the parents on not following up, but we have to also take ownership. And before we operate on a patient, there has to be a mutual agreement from parents and from the surgeon that we're going to stay together, that I have to see this patient from all these times, every month, then every 3 months, then every 6 months, then every year. So that's my comment number one. My second comment is when you show us the contrast enema, we see a massively dilated colon. So if this patient was in front of me and I was gonna reoperate on this patient, most likely I would have done a colostomy. And because I cannot imagine doing a transanal in such a dilated colon. So I think I would have done a colostomy first and then attempt a reoperation. And the other comment, you mentioned that because of this dilation, you had to taper this colon. So I get very concerned if we are going to have a tapered line of sutures in a circular lines of suture. If you have a normal sphincter, this is a very high risk for a leak or for a fistula. So those are my comments, but I am so happy the patient is doing well. But again, don't let this patient go. This patient needs to be monitored so he doesn't suffer from diarrhea, from constipation, and he continues to do well. Do you want to comment?
Yeah, well, congratulations on your patient.
Thank you.
You did not mention anything about histology. So I'm assuming that during the operation, you use as a guideline just the external and macroscopic appearance of the colon to decide which one was aganglionic, which was not. So did you have any histologic studies done pre-op, post-op, or transoperatory? And the next question, the bowel is working, but is the patient fecally continent? Is another question.
Thank you. Yes. A good question. No incontinent.
Sorry, we didn't hear Dr. Moon.
Yeah. No incontinent. This patient. Good continent.
Okay. Dr. De La Torre, do you have any comments?
No, thank you. You already did all the comments.
What histology?
He mentioned in the specimen, post-operative, the distal portion was aganglionic, but the proximal portion was ganglionic.
But during the operation, you just follow you just observe the external appearance of the bowel. You didn't have intraoperative histologic studies, right?
Did you have frozen section or intraoperative? How did you know which segment had ganglion cells? Just by looking at the specimen? I think that's Dr. Peña's question.
Yeah. I have no frozen section, and I perform identified macroscopic and barium enema, and my CT many cases is sprung 1 month in 10 cases, and 1 year, maybe 1 or 200 cases.
Okay, well, congratulations. Thank you very much, Dr. Moon. So now we're going to invite our next presenter, that it's going to be Dr. Alfredo Muñoz. He's originally from Mexico, but it's spending a year with us here in Alfredo Dominguez, spending 1 year with us here in Colorado. Welcome, Dr. Dominguez.
Hello, everyone. Good morning. The case that I'm going to present is about a 12-year-old boy patient with a very complex medical history. The patient was diagnosed with Hirschsprung disease in the neonatal period and underwent a laparoscopic assisted pull-through and rectal Botox injection when the patient was 3 months old. According to the mom, the patient did well for 3 years. But when the patient was 3 years old, the patient started with obstructive symptoms referred as nose stooling, nausea, and vomiting. A contrast enema and a rectal biopsy were performed, ruling out a retained Hirschsprung disease. So the patient was referred to the GI service, and they tried polyethylene glycol, Sina, and Botox without any improvement. So the patient was stooling only with irrigations. So at this point, the patient continued with obstructive symptoms. The X-ray shows a very dilated left colon, as we can see. So what would you do now? Keep irrigations, Botox injection, colonoscopy, ileostomy, or a colostomy. So the surgeon who was in charge of the case decided to do a laparoscopic assisted loop ileostomy in order to decompress the colon and to rest the colon. After the surgery, the patient was doing great, the patient was gaining weight and was asymptomatic. So 1 year later, the patient was taken to the OR for an ileostomy closure with ileocecal resection. So after the ileostomy closure, the patient continues again with obstructive symptoms, nausea, vomiting, and abdominal pain. And again, the X-ray shows a very dilated colon, as we can see. So the patient had to restart irrigations. So what would you do now? A workup for persistent obstruction, a redo pull-through, an ileostomy, a colostomy, or a Botox injection. So a workup for persistent obstruction was started, and the rectal manometry shows an absence of the rectal anal inhibitory reflex, and the simulation defecation showed relaxation. A new Botox anal injection was done, and the colonic manometries was suggesting a poor colonic motility throughout the colon, primarily in the descending colon. So with these findings, the surgeon took the patient to the OR and did an laparoscopic placement of cholecystomy, and antibiotic enemas were started. However, the history continues and successful antibiotic enemas were reported. The enemas didn't come out to the anus, and after every flush, the patient required rectal irrigations. So now the plan was to do a contrast study through the cecostomy tube and take the patient to examination under anesthesia. This is the contrast study, and as we can see, there is a dilation of the entire colon, primarily of the descending colon and the sigmoid. The rectum didn't look that dilated, and there is also a reflux of the contrast enema to the small bowel. In the rectal examination under anesthesia and the full thickness rectal biopsy was done and was reported to have a good sphincter and intact pectinate line. In the pathology department report, no ganglion cells, no hypertrophic nerves, extensive small muscle hyperplasia and fibrosis in the submucosa. So the patient was taken to the OR, and what they found is a very dilated colon, primarily dilation of the descending colon and the sigmoid, a J tube, which was okay, the ileocolonic anastomosis without the ileocecal valve, and what they performed was a proctocolectomy of 20 centimeters. The descending colon was tapered, and a pull-through of that tapered descending colon was done. And finally, a transverse colostomy with mucous fistula was created in order to protect the pull-through. The pathology department reports the presence of ganglion cells, circumferential at the proximal and the distal margins, and throughout the entire resection length without nerve hypertrophy or eosinophilia infiltrate, which means that the pull-through was done in the ganglionic segment. The patient was doing great, so the colostomy closure was in mind, and a distal colostogram was done. And we can see that the distal colon was fattened, but the patient was holding voluntarily the contrast. The rectal exam rolled out any structure, and the patient was sent to physiotherapy to learn how to relax, and the dilation continues. So 4 months later, at the age of 8 years old, the patient underwent a colostomy closure, and the patient was seen 30 days after the surgery. The patient was doing great, the X-ray was clean, the patient was fecal incontinent, urinary continent, and it was on irrigation twice a day. A bowel management was started with integrated enemas. So the problems continue. The enemas to the cecostomy produced nausea and vomiting. The patient was required to do rectal irrigation after every flush, and the patient continued this way for almost 3 years. So the first time that this patient was seen in the colorectal center at Children's Hospital, Colorado was when the patient was 11 years old. The patient had no bowel movements with integrate enemas. The nausea and vomiting continued, and the patient required rectal irrigations, and the x-rays was clean and the colon was decompressed, as we can see in this image. So the question now will be, with these symptoms and the medical history, what would you do? A rectal manometry, a contrast enema, examine under anesthesia, full thickness rectal biopsy, or B, C, and D are correct. So the plan was to do a contrast enema to the J tube in this one that I am showing you. And we can see a patent colon and very dilated left colon, and also a reflux of the contrast material to the small bowel. And the patient was taken to the OR for examining under anesthesia, and the digital exam revealed no mechanical obstruction, but a tight anal canal with immediate explosive liquid bowel movement. And we can also saw an incomplete anal canal in all the circumference. So the patient was scheduled for a resection of the left colon. When the patient was 11 years old and 11 months, the patient underwent a left colectomy with colorectal anastomosis and Botox injection. And what we found was a massive dilation of the left colon, and the pathology department report a ganglion cells present in that left colon. However, in the day 6 postoperative, the patient continued with significant bilious drainage through the NG tube, no effective anterograde enemas, which were producing nausea and vomiting, and the patient was requiring rectal irrigation to resolve the symptoms. So an upper GI with a small bowel through was done, which ruled out any mechanical obstruction in the small bowel. We can see how the contrast reaches the colon, but the contrast stopped exactly at the level of the transverse colon. So now a contrast study through the cecostomy was done. The patient was placed in a left lateral position, and we can see how the contrast stopped again in the transverse colon. So finally, we did a contrast enema to the rectum, and we can see an obstruction site at the level of the splenic flexure. So the patient was taken again to the OR, and exploratory laparotomy was performed. And what we found was a very dilated right colon, an important colon ileum reflux, an obstruction of the anastomosis on the site of the previous colostomy, intrinsic and extrinsic, and a functional and mechanical obstruction of the distal colon. So with these findings in the OR, what would you do? A redo pull-through, a total colectomy, an ileoanal anastomosis, a ileostomy, a left colectomy, permanent end colostomy, or resection of the cecostomy. So when the patient was in the OR, these are the findings. So the right colon was very dilated, the colorectal anastomosis and the cecostomy were okay. We can saw the ileocolonic anastomosis without the ileocecal valve, and there was an obstruction on the site of the previous anastomosis, the one from the colostomy closure. And what we did was to resect all the left colon. The distal colon was closed in a Harman pouch. The cecostomy was closure, and an M colostomy was created. So the patient was discharged 10 days after the last surgery. The patient was eating, stooling through the colostomy, and was gaining weight. And finally, the patient was saw in clinic 2 weeks after the surgery, and the patient is doing very great. Thank you very much.
Dr. De La Torre, do you want to comment?
Yes, this is a unfortunate case. The patient was born with Hirschsprung. with a 7 centimeters aganglionic. And usually these patients have a very good outcome. I mean, 50 or 30%, they have some colitis, whatever, but they don't end with this type of end colostomies. In other words, this patient had something, we don't know what happened because it was in another hospital. Probably he didn't have a good bowel management or good program of irrigations after the pull-through. And the colon started to grow and have huge dilation. At that point, one of the surgeons decided to do a tapering because the colon was so big that they were not able to perform the pull-through and pass the colon through the pelvis because it was very dilated. Unfortunately, one of the biopsies was reported aganglionic, but it was very low. This is another point that I want to stress. This patient had a good pull-through, at least histologically was in a euganglionic or normal ganglionic zone. And then the biopsy was taken very low. And this report invites to the surgeons to do a redo. I'm very positive that this patient needs a redo pull-through because it was very dilated. But at the end, the colostomy and then the pull-through create 2 zones of obstruction. And for 11 years, the patient only had bowel movement with irrigations. Another important point in this case is the J2, the cecostomy. Patients with Hirschsprung, with complete anal canal, obstruction, and dilation of the colon, they do not tolerate antegrade enemas. To me, is a contraindication to do a cecostomy in a patient with severe hypomotility, severe dilation of the entire colon, and distal obstruction. And this happened with this patient. Every time the mother did a antegrade enema, the patient started to have vomiting, nausea, and the mother have to insert a catheter in the rectum to get all the flush and then end in doing irrigations. I think this is some of the very important aspects that we can learn about this case.
I have a question. Is the patient going to stay with a colostomy for life?
Yes, it's an end colostomy for life. We talk with the family during the operation. The patient has damage of the anal canal, and we don't want to do a pull-through with ileum.
Okay, so I think this is a very complex case, a very complex story, and we cannot help but wonder if the story would have been different if the patient was managed since day one by someone with experience. Of course, in medicine, there's no way to go back and change the story, but I think that's the question that we all have, was if this patient was managed day one aggressively and without loss to follow up and properly managed, would the story be the same or would it be different? Of course, we don't know, but I think that's what we all have to keep in our minds and remind that we are dealing with a patient that will have consequences for life. So if we don't have experience in managing such cases, it's better to go and to send the patient to someone with experience.
And another thing.
There is a question in the chat. Go ahead, Alberto.
And another question is, all of us are familiar with the history of Hirschsprung disease, and the story goes ganglion cells or no ganglion cells. But now we have learned that this story in Hirschsprung is more complicated than ganglion cells and no ganglion cells, because some patients have one resects all the aganglionic segment, and they have no mechanical obstruction, and yet some of them have serious motility disorders with ganglion cells. So the question in this patient, all this dilatation of the colon was a consequence of a remaining aganglionic segment, was the consequence of a mechanical obstruction, or is just a primary motility disorder that sometimes is present in patients with Hirschsprung disease?
This patient, we don't know. He had a manometry that expressed severe hypomotility, mainly on the left colon. The surgeon, when he did the second pull-through, he described very fibrotic pelvis. It was very difficult to do the pull-through with a lot of scar tissue. So we don't know what happened in the first pull-through. So, and then the damage of the anal canal. I want to answer the question from Dr. Chistoma. If this patient had already 2 pull-throughs, and the second one already described very difficult pull-through because the pelvis was almost frozen, fibrotic, and then you want to do a pull-through in a patient with this pelvis and severe damage of the anal canal, the chances are to have the same outcome. If we want to preserve this dilated colon and do the pull-through of the left colon, which is already with chronic damage, chronic dilation, is going to have most probably the same outcome. No good bowel movement, and the patient is going to need irrigation. Second, the stenosis from the colostomy closure was significant, and we have to resect that part. So the only portion that we have for a possible pull-through on the left colon was 10 centimeters of very dilated colon. So that's why we decided to remove the left colon. And we talked with the family, and the family, after 11 years, imagine, mommy was crying because she was very happy because we decided to do an end colostomy forever. It was the most happy news in her life when I talked to the family and I said, I need to do a colostomy. And the mother said, and it's going to be forever? And I said, yes. And she said, thank you very much, it's what I want. So that happened in Houston.
Thank you very much, Dr. De La Torre. So now we're gonna invite Dr. Monica Nanda to present another Hirschsprung case, and Ray's gonna be sharing the presentation.
Yeah. So, can you hear me? Yeah. So this is a complicated case of complicated Hirschsprung disease. We had a 3-year-old child who has come now with a proximal transverse colostomy, and with now he has got a redo pull-through done, which is now almost 5 months after pull-through, and he's waiting a colostomy closure. Now I'll deal with the past history of this child. That is, the child had a modified Duhamel procedure. That's a single stage procedure at 1 year of age. Followed by that, he had a transverse colostomy just 1 month after that, because he was diagnosed as a case of perforation peritonitis. Then a distal cologram was done on after 1 year, almost after 6 months, which was suggestive of a stricture at the coloanal anastomosis. After this, colonoscopy was done under general anesthesia, which showed the stricture 1 centimeter above the dentate line. And so the child had a balloon dilatation of this stricture and was kept on serial rectal dilatations. Following which, in March 21, a colostomy closure was done. But on second postoperatively, the child developed features of obstruction again. So a re-exploration was done after the second day, in which a colostomy was done. There were some adhesions which were removed, and there was the stricture which was appreciated again by then surgeon, and so a rectal stricturoplasty was done as per the records. Now, child after that was lost to follow-up for 2 years, and then he was taken up for a diagnostic colonoscopy when he came for a redo closure. But we also plan to do a rectal biopsy to see just in case if we are missing something in January 2022. Now, the rectal biopsy, which was done again, it showed the absence of ganglion cells. So therefore, the child was planned for a redo pull-through. And these were the colonoscopy reports, which said that the child does not have any kind of stricture now. The colonoscope could be passed easily, but the biopsy showed absence of ganglion cells. So we decided on a redo pull-through. And next slide. This is the rectal biopsy report, which was done about 1 centimeter, means about 1 to 1.5 centimeter above the dentate line. And there were staples of the old Duhamel, which could also be seen, and some of the part was taken up. And then the child underwent a redo pull-through on April 2022. A frozen section was taken at multiple sites, and that biopsy suggested transition zone in the rectosigmoid region and presence of ganglion cells in the descending and transverse colon. So therefore, there was the mobilization of the colostomy was done, and the ascending colon and cecum, they were all mobilized, and the part of the sigmoid was resected, and the rest of the colon, that is the left colon, the right colon was mobilized, and the left colon was finally above, that is the descending colon, was pulled through, and a coloanastomosis, anal anastomosis was done just proximal to the dentate line. I have a figure also, I think in the next slide. Can we? Yeah, this is the line diagram. So the first one is the old colostomy site, and the old colon which was there, that part was resected, which shows some zigzag lines, and the part which was pulled down was basically the proximal descending colon, right from splenic flexure, and that part was pulled down, and a coloanal anastomosis was done. Yeah, next slide if we can. So then the biopsy which was given of the resected sigmoid colon, which also suggested that there was absence of ganglion cells in the lower segment, but on the distal part which has been resected, the ganglion cells are present. So now so this is just this thing that an early development should suggest that there is some transition zone is remaining, an early development of enterocolitis. I think the moderators can throw some more light on this. And can you come with the second slide? Yeah. So one question which I want to ask is, does the audience suggest an alternative way of management in this case? Polling is not. And then now the present examination after the redo pull through, when the child has come to us, on perrectal examination, I could feel a fibrotic ring, means that was done at 3 months post pull through. The anastomotic site approximately 4 centimeters from the anal verge. And this admits the index finger easily, and a 15 by 16, that's a quite thick dilator, which it goes easily. Child is on daily dilatations and distal stoma wash and is again awaiting a colostomy closure. Now, my main hitch in this child is with that, should I wait for this fibrotic ring? Because I think that if we give some more time to the child, maybe 6 months or so, the fibrosis, it may settle down and it may help in colostomy closure. That is my thought. And so I just want to ask the moderators and the people also that what is the next best step for the child? Should we go in for a colostomy closure? If yes, when? Or should this child be kept on a permanent colostomy? Thank you.
Thank you, Dr. Nanda. I'm curious to hear everybody's comment. I'm gonna give my comment. This is a Duhamel. So there is a portion of aganglionic rectum, and then you're talking that there is probably a narrowing. So it is hard to predict if when closing the colostomy, if the patient would do well or not. But we also have to take into consideration that reoperating on this child would be the fourth pull-through. So whenever we reoperate on a patient that we did not do the primary pull-through for Hirschsprung, we do not guarantee bowel control. So yes, you could reoperate on this child, but the chance that this child will not have bowel control is very high, and it's important for parents to know. So it's very hard to comment without me examining and seeing what's the level of the stricture. If it's a real stricture, I agree that you're going to close this colostomy and this patient will have problems. So I would have a tendency to reoperate with a protective colostomy. And then when I close the colostomy, consider doing a Malone, just with the suspicion that this patient by the fourth pull-through will not have bowel control. Certainly a difficult case, and I think we always emphasize patients with colorectal conditions, they have one chance for a good operation. Reoperations are harder and the prognosis is not the same. Can I comment?
So I confess that I have a
Prejudice.
prejudice against the Duhamel procedure because I have seen many patients years after the Duhamel with a very dilated rectum. The rectum that is left there the rectum is still there, and that is against the basic principles of the treatment of Hirschsprung disease. The advantage that I see in Duhamel procedures is that the pectinate line is preserved and the anal canal is preserved most of the time. So my inclination would be to reoperate on this patient, remove that ganglionic rectum, remove that stricture, and connect normal ganglionic bowel above the anal canal. I know that this sounds very easy in theory and may be very, very difficult in a patient that had 3 pull-throughs, but that would be my idea.
Dr. De La Torre?
Yeah, thank you, Dr. Monica, for this case. My suggestion is when I have a patient with a Duhamel and I need to do a redo, I do a transanal resection of the rectum all the way, like a Swenson, transanally, and then a laparotomy to do a pull-through. In other words, I resect completely the Duhamel. Is one of my suggestions. If you have a stenosis after this last pull-through, and you cannot rescue this anastomosis, I believe you did an anorectal anastomosis, what you said. So you can try to do the dilation And if not, this patient needs to probably have another pull-through or a colostomy. I don't know how is
Okay.
the dentate line. I don't know how is the anal canal. It was very useful if you present how was the contrast enema before and after.
Okay. Yeah,
Thank you very
contrast
much,
and
Dr. Yeah, go ahead.
yeah, the contrast enema films are actually not available. But yes, the anal canal is patent. The anastomosis is just at the dentate line itself. It's just at the dentate line.
Okay, very good.
Okay, I think this is a hard case, and if the anastomosis is right at the dentate line, a reoperation, as I mentioned, would result in fecal incontinence. So I think the parents should be aware of that. So it's either closing the colostomy with a high chance of failure, but high chance of bowel control. And if it doesn't work, then a reoperation knowing that it will be fecally incontinent. It's a tough case, but thank you for presenting, Dr. Nanda.
Thank you so much. Thank you.
Okay, so to end our meeting in a happy note, we will finally have one Hirschsprung case that it's a primary case that it will be presented by Dr. Leah Wehrli. She is originally from Switzerland, but she is our colorectal fellow for 2 years. Welcome, Dr. Wehrli.
Thank you very much. Let me just share my screen. Hope you can all see it. Good morning, good afternoon, or good evening, wherever you are. So I'm happy to present the last case, which is a now 22-month-old boy, so almost 2 years old. He has a medical history that he was born full term and he passed meconium, mom says, within the first 48 hours of life. So it took him a while to pass his meconium. Then apparently he was having bloody stools at the age of 1 month. And due to that, his formula, so his milk formula, was switched and he was diagnosed with food protein proctocolitis and was not having any further bloody stools after switching the formula. But at the age of 1 year, he was constipated and it was getting worse. According to mom, when we saw him at the age of 18 months, he was having a bowel movement every week, so once a week. He was draining a lot, and he was then able to evacuate, but was having explosive watery stools. Sometimes the consistency was more like clay, and the color of the stools was either gray or yellow, but it was never formed and it was never brown. Mom tried different laxatives. She was trying polyethylene glycol and was increasing the dose. So he was having watery stools, but still was straining a lot, and it didn't really improve his symptoms. Based on these findings, we also asked the mom what about his growth curve and his development. And he was developing normally, and he was gaining appropriately and growing appropriately. On clinical exam, his abdomen was distended, but it was soft. We couldn't really hear a lot of bowel sounds. His anus was orthotopic, located within the sphincter muscles. And on the backside, so his spine didn't show any signs for spinal dysraphism. So no signs for spina bifida occulta. That was his first X-ray of his abdomen. And you can see there is a lot of stools in his pelvis all the way up. Now, my question to you, what is your differential diagnosis? Chronic idiopathic constipation, Hirschsprung disease, anorectal malformation with perineal fistula, anal stenosis. Which is your preferred differential diagnosis? Okay, 76% of you said Hirschsprung's disease. Let's see how the case develops. Next question, what diagnostics would you do? Would you take the boy and do an exam under anesthesia while he's asleep? And would you take a full thickness biopsy? Remember, the patient is 22 months old. Would you also again and do a contrast enema? Or would you do an exam and a suction rectal biopsy without anesthesia in your clinic? So would you do choice 1 and 2? Or would you do choice 1 and 3? Or just choice 1, 2, or 3? Okay, so 64% said exam under anesthesia with a full thickness biopsy. That's exactly what we did. We did the contrast enema first. And that's the video. So you can see the Foley is inserted a little high, and you can also see that the balloon is inflated, which we typically don't do, but in this case, it is. And you can see that the sigmoid is very dilated. It fills up and up. And the rectum is rather narrow and spastic appearance. Sorry, I'm trying to advance the presentation, but it's stuck. So hang on with me, please. Interesting. Okay, let me just figure out how to advance the.
If you try to reshare it, I think that'll clear it up immediately.
Yeah, the thing is, I can't. It's kind of frozen.
Hold on.
Yep.
No, I can't do it either. So
Did you try to press ask, Leah?
I did.
See?
Sorry. Yeah. Unfortunately, let's see what I can do.
can you give me a remote control?
Yeah, I'm trying to. Sorry.
Okay. Dan, you are definitely stuck. So
Yeah.
what I'm going to do is stop your sharing so you can share again.
Okay. Yeah, sounds good. Seems like I can't do anything. So, I mean, I can just present without this slides.
Do you have her presentation? Ray?
No, let me see. I can send you.
I think Dr. De La Torre or Ray should have your presentation.
Let me just. Okay, so I send you the presentation, but I can talk without the slides. So what we essentially did is we took the.
I can share the presentation.
Okay, perfect. But I'll go on and present. So what we did is, as you can see on the contrast enema, the rectum was very narrow, spastic, and the distal sigmoid and proximal sigmoid was very dilated. So we took the patient to the OR. Next slide, please. And got a full thickness biopsy. Next slide, please. Next slide. Next slide. Okay. That's also an X-ray of his abdomen where you can see there's like a very air-filled colon throughout, especially the sigmoid is very dilated, and the rectum here again, you can see there is no air in the rectum at all. So next slide, please. So we got a full thickness biopsy, and in the biopsy, the pathologist told us they could not see any ganglion cells. The calretinine staining was negative, and they could not see any hypertrophic nerves. Next slide, please. So what's your diagnosis? Would you say Hirschsprung's disease, chronic idiopathic constipation, or anorectal malformation? So since Dr. Bishop mentioned already that's about Hirschsprung's, I guess everybody already knows it's Hirschsprung's. So yes, it is. 89%, wonderful. Okay, next slide, please. Okay, I just want to brief talk about the significance of these histopathological findings. I think we all agreed no ganglion cells is a classical, or it's a gold standard for diagnosing of Hirschsprung's disease. The meaning of that the calretinine stain was negative means that the nerve fibers coming from the ganglion cells did not stain, meaning there were no nerve fibers or essentially no ganglion cells. So that's also a finding that supports your diagnosis of Hirschsprung's. The meaning that there were no hypertrophic nerve fibers. The importance here is that hypertrophic nerve fibers above 40 micrometers is something that is reported in patients under the year of 1, meaning that there are no norm values reported in the literature for patients that are older than 1 year. Again, this patient was almost 2 years old, but in this case, no hypertrophic nerve fibers were seen. There's a paper published from Raj Kapoor saying, and other groups saying that if there are no hypertrophic nerve fibers seen, that this can be a sign or can be associated with a longer segment of Hirschsprung's disease, just as a side mark. Next slide, please. Can you please, yeah, thank you. So what kind of medical treatment would you give to this patient until the date of the OR? Would you do rectal enemas, rectal irrigations, or Botox injections? So we bridged this patient with rectal irrigations until the date of the surgery. Next slide, please. And we performed a transanal full thickness Swenson pull-through. An incision was made 1 centimeter above the dented line. And then we proceed. We took a biopsy full thickness at about 5 centimeters. It was negative for ganglion cells. So we proceed and we took another biopsy at 25 centimeters, which showed ganglion cells. To be sure that we are not having a transition zone pull-through, we went 5 centimeter proximal. So essentially 30 centimeters of colon were resected. The proximal margin, or so-called donut, was then looked under the microscope by our histopathologist, and they reported that there were ganglion cells throughout the circumference. And then a colorectal anastomosis was performed. Next slide, please. These are the intraoperative pictures. Oh, something happened here. So what we did is we placed multiple silk sutures above 1 centimeter above the dented line, and then performed our full thickness Swenson pull-through. Thank you very much. Okay.
Thank you, Leah. I'm sorry that your computer froze. but we just wanted to end in a happy note after so many sad cases of Hirschsprung. This one had a late diagnosis, so to be perfect, we would have wished that the diagnosis happened sooner and we would not have such a dilated colon. But I am hopeful that this patient will do very well and will not lose follow-up, because we wash the brain of our parents, of patients, and I know that this is Dr. Luis de la Torre's patient, so he will follow him closely to assure that he's doing well. So there is a question, nowadays, do you prefer transanal Swenson or Suave, and why? So I do Swenson because I am very familiar with the full thickness dissection from operating patients with anorectal malformation.
Yeah, I would rather make a comment about the contrast enema. You have to talk to the radiologist. He passed the catheter too far, too deep, and inflated the balloon. Those things are not necessary. You're supposed to pass the catheter a little bit and inject contrast material. And so the radiological changes in this patient were so obvious of Hirschsprung disease that even with the poor radiological technique, it became clear that the patient had Hirschsprung disease.
Dr. D?
Yeah, the contrast enema was done in another hospital, so we don't know
That's good.
how to fix that.
That makes
More
us feel
education
better.
on
That's
radiologist. Mhm.
Perfect. Let me see. Luis, do you want to comment between Swenson and Suave?
I did for many years transanal endorectal. In other words, Suave. Then publications from other surgeons, mainly from Cincinnati and nationwide, they claim that the rectal cough was causing a lot of problems like enterocolitis, etc. And then they did reoperation in all these patients with very bad results, saying that these patients now are fecal incontinent. So I switched from Suave to Swenson just to see what happened with the patient, because I have many patients with Suave, and I can tell you it's the same frequency of colitis after the pull-through. Swenson versus Suave is the same outcome if you do a good operation.
There's another question about the prognosis of this patient with dilated colon and the risk for enterocolitis. So what we normally see is enterocolitis. If the patient has enterocolitis before the operation, high risk for having enterocolitis after the operation. If the patient didn't have episodes of enterocolitis before the operation, low chances of having enterocolitis after the operation. That would be my comment.
Yeah, this patient never had an event of enterocolitis before the operation, so I'm expecting that he's not going to have enterocolitis.
So there is a very good question.
This is the amazing word. Yeah, say it again.
There is a very good question that I would like Dr. Peña and Dr. De La Torre to answer. In the absence of frozen section in your hospital, what would you suggest? Just rely on gross finding or the barium enema film, or what? If you don't have frozen sections.
Frozen section. If you don't have frozen sections, I would take preoperative biopsies, and for me, that would be enough. In other words, it's not indispensable to have the frozen section. If you have that, that's great. But if you don't have it, you have a good preoperative full thickness biopsy, and then you go just by the microscopic findings.
So what Dr. Peng is saying, just map the patient with full thickness biopsies before, wait for the results of permanent section, and then plan the pull-through. That would be the safest.
Yeah.
What do you think, Dr. De La Torre?
Yeah, I agree. The frozen sections is, if you are going to do a primary pull-through, it's mandatory to have frozen sections, and you need to trust in the pathologist. If you don't have frozen sections, or the pathologists are not very good reading frozen section, you need to go back and do the pull-through in 2 or 3 stages. In other words, you need to do a laparoscopy or laparotomy to do the biopsies. You can create a colostomy and wait until you have all the biopsies on permanent section.
Perfect. Well, we are a little over time, so I would like to thank everyone for the wonderful presentations. And again, we had pediatric surgeons joining from Chile, Libya, South Africa, Philippines, Indonesia, Mexico, India, Uganda, Turkey, Uzbekistan, United Kingdom, Colombia, Iraq, Peru, Pakistan, Romania, Argentina, and Slovenia. I hope in United States. I hope I mentioned everyone, and we look forward to see you on October 27 for another monthly international colorectal web meeting. Thank you very much. Nigeria, I missed that one. Thank you.